Welcome, and thank you all for attending this session today. I am going to go ahead and get started. So my objectives for today are to review the genes and hereditary cancer syndromes that impact women's cancer risk. Then we will go on to review who is a good candidate for genetic counseling and testing. And then we will review cancer risks and medical management options, including targeted therapies associated with specific genes. And then we will wrap up with a review of the testing process, the types of results that can occur, and the importance of cascade testing, which is the concept of reaching out to family members and testing to help with prevention strategies. But before we get started, I'd like to just provide a couple of definitions. A lot of people ask, what is genetic counseling? So genetic counseling is a process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. And this can be for diseases other than cancer. Genetic counseling is a common occurrence in the prenatal setting, in the pediatric and adult setting, as well as in the cancer setting. So lots of different areas that genetic counseling can occur. And then a definition for genetic testing. What is genetic testing? It's a type of medical test that identifies changes in chromosomes, which are the packages of genes, the actual genes themselves, or the products of genes, which are proteins. So the results of a genetic test can confirm or rule out a suspected genetic condition. So if you're looking to know whether you have muscular dystrophy because of symptoms that are present, or whether you have a hereditary form of cancer based on a cancer type that you have, genetic testing can help with that. It can also help an individual who doesn't have a disease understand whether they may be at risk in the future for developing that disease, or whether they may pass on that disease to their children. And so then if we combine those two definitions, what is cancer counseling and genetic testing? And this is the process of meeting with individuals and families to review and discuss personal and family histories of cancer, discuss risks for developing cancer based on this information, the discussion of whether genetic testing is appropriate based on that history, and then talk about recommendations for screening and prevention and risk reducing measures. And then to talk about the psychological implications. How do individuals deal with this information with cancer in their family, results of genetic testing, risk reducing measures. And then that information is communicated between families and their providers so that everybody's on the same page about what are those risks and what are the recommendations for screening and prevention. So with that as our introduction, I'd like to start with some basic information about cancer genetics. So all cancers are genetic in origin, and that's an important concept because people will come to us and say, oh, I want to understand if my cancer is genetic. Well, by definition, all cancers are genetic, but only a small proportion of cancers are actually inherited. And so what we have to understand is that when we're talking about somatic variants, we're talking about changes in the body cells. So it could be the breast, the colon, the lung, any of our body cells. If you have mutations, those are typically acquired mutations, and they're not things that are hereditary. And the majority of cancer is due to somatic variants, acquired mutations. When we talk about germline variants, we're talking about variants that occur only in the egg and the sperm, that occur in the egg and the sperm cells, and those can be passed on to the next generation. And then those variants are in all the cells of the body. And this accounts for about 10% of most cancer types. And this is where I'm going to focus today, is on these germline variants. But at the very end of the talk, I am going to come back and talk a little bit about the importance of understanding these somatic variants as well as it pertains to therapy. So this is just a schematic to help understand the difference between a sporadic cancer and a cancer that could be inherited. So if in the cell that you're seeing here, you have two copies of a chromosome. So all of our genes come in pairs. You get one chromosome with a package of genes from mom and one chromosome with a package of genes from dad. And so what happens in sporadic cancer is you have to acquire mutations in these genes. And so this just shows that there's a hit here, a mutation, but you still have a normal copy on the other allele. So you don't have cancer, and additional events have to occur through the environment, through other processes in order to get that second hit. So now you don't have any working copies of that gene, and that can then start the process of a cancer cell. Pretty simplistic description. But what happens in the inherited setting is that you're born with one of these mutations on one of these alleles, and so you're one step closer. So you're not born with cancer, but you're more susceptible because of that first hit. And still things have to happen through the environment. You have to acquire additional mutations, but you may see cancer at younger ages, and you may see individuals getting more than one type of cancer or have a family history. And so when we think about hereditary cancer, we think about 10% of cancers having an identifiable germline mutation that increases susceptibility to developing cancer. Familial cancer just refers to the idea that there's a family history. So there's more than one individual with cancer in a family, so it's familial. And some of those may in the future turn out to actually have one of these inherited mutations, or it may be just because cancer is a common disease, we're seeing a clustering in family, and those cancers are really sporadic in origin. So what are some of the red flags for thinking about whether there could be a hereditary cancer risk? Young age at diagnosis is really important. So particularly in cancers like breast or colon cancer, we think about cancers under the age of 50. Pathology is important in thinking about this, and triple negative breast cancer is a cancer where the estrogen, the progesterone, and the HER2 receptors are all absent in the tumor tissue. And those types of cancers are more common in the hereditary setting. Women with ovarian cancer who have a type of ovarian cancer called high-grade serous, that type of cancer is more common in the hereditary setting. Rare cancers, so when we see a man with breast cancer, or cancers like what are called sarcomas, which are cancers of the soft tissue or the bone, and pheochromocytoma, and these are just examples. That's a rare tumor that occurs in the adrenal gland. So when we see rare cancers, we think about genetic testing or hereditary factors. People who go on to develop more than one type of cancer in their lifetime. So not a recurrence of a cancer, but two separate or more types of cancers. And then family history is very important. So when we see relatives that have the same or related cancers in a family, like breast and ovary, colon and uterine, those are cancers that, as examples, can cluster in families when there's a hereditary risk. So the family history is a very important piece of information in our evaluation process. And this is just an example of what we call a pedigree or a family tree, genogram, lots of different names for this. And so what you're seeing here is a woman who's coming in. So circles refer to females, squares are males. This is a young woman who's coming in for genetic counseling. And so what we want to do is obtain her maternal side of the family and her paternal side of the family, and ask lots of questions about who in her family may have had cancer to get a sense of whether there's a risk. And so just to give you an example, here is the family history that she reports. She has a sister with, sister with breast cancer at a young age, a father with pancreatic cancer, an aunt with ovarian cancer, a cousin with breast cancer, and a grandmother with breast cancer. You can see that the ages here are quite young. And this is a concerning family history for thinking about hereditary factors. But I think it's important to remember that family history can also not always be helpful in doing this process, and that a lot of families are small nowadays. People aren't having as big of families as in past generations. And sometimes if you're looking for a history of, say, breast or ovarian cancer or prostate cancer or male breast cancer, and the family is small and there are very few females or very few males, you're just not going to see a pattern in a family. And that's not that there isn't the existence of a hereditary variant, it just means your family history isn't informative. And some people don't know a lot about their family history. If you're adopted, or, you know, in past generations, people didn't talk about cancer. And so, you know, sometimes people can't retrieve that information. And if people have had surgeries in the past, so say, you know, women in the family have had hysterectomies, including removal of the ovaries in past generations, that would have reduced their risk. That's not why they had the surgery done, but that can limit the informativeness of the family history. People who have colonoscopies, we're doing more colonoscopies now, which is great, but that means if somebody's had polyps and are removed, they're not going to get colon cancer, and so we may not see that history. So just little caveats that we have to think about when we're taking family history. So now I'm going to talk a little bit about breast and ovarian cancer and some of the genetic relationships to these two types of cancers. So it's important to remember again that only about 10% of breast cancers are actually due to inherited variants. The majority are due to mutations in genes called BRCA1 or BRCA2, breast cancer gene number 1, breast cancer gene number 2. But it's important to know that we have also learned in the last few years that there are a number of additional genes that have been linked with hereditary breast cancer. And so we rarely just test individuals for BRCA1 and 2 anymore. When there is a history of breast cancer, we're really looking at some of these additional genes. And the same goes for ovarian cancer. More ovarian cancer is hereditary than breast cancer. More like 10 to 20% of epithelial type ovarian cancer is due to hereditary factors. Again, the majority due to BRCA1 and BRCA2. There's a smaller portion due to something called Lynch syndrome, which I'm going to talk a little bit more down the road. But newer genes called BRIP1, RAD51C, and RAD51D are newly discovered genes that are involved in hereditary ovarian cancer. And this just gives you a sense of the landscape of what we're dealing with now, is that, you know, of the 10% of breast cancers that are inherited, you can see here that, you know, probably half of that is due to BRCA1 and 2, but look at all the genes that have now been discovered that are related to breast cancer risk. CHEK2, ATM, and PALB2 are sort of the three most common genes that we find mutations in after BRCA1 and 2. So again, the importance of thinking about testing for more than just those two genes. And for ovarian cancer, more than half is due to BRCA1 and 2, with BRCA1 having a greater proportion. But again, look at all these other genes that have now been linked. And so this has really changed how we think about doing genetic testing. But I am going to focus on BRCA for a minute, just because those genes are the most common when it comes to hereditary breast and ovarian cancer. So again, how do you know whether you might be at risk for having a BRCA mutation? Well, if you've had breast cancer at a young age, under the age of 50, if you've had a triple negative breast cancer, those would be things to consider doing BRCA testing. If you've had more than one breast cancer, and again, not a recurrence, but two different primary breast cancers, if you've had breast and ovarian cancer, if you've had ovarian cancer at any age, and particularly if it's the high-grade serous type, that is a single indicator for thinking about genetic testing. Male breast cancer at any age, again, single indication for thinking about testing. If you have Ashkenazi Jewish heritage, and I'll get to that in a second, sorry, that is an indicator for thinking about testing. And there are two new indications in the last couple of years, including men with prostate cancer, particularly men diagnosed under 65, and have a Gleason score of greater than 7. And that's just a measure of aggressiveness of the type of cancer. And then individuals with pancreatic cancer at any age. So we do have some newer indications for thinking about BRCA testing. And individuals who are of Eastern European Ashkenazi Jewish heritage have a higher rate of carrying certain BRCA mutations than people in the non-Ashkenazi population. And there's about a 10-fold difference in that 1 in 40 individuals of Jewish heritage will carry one of 3 mutations. 2 of them are in BRCA1 and 1 is in BRCA2. And so the threshold for thinking about testing in somebody who is of Jewish heritage is lower than for thinking about somebody who is of non-Ashkenazi heritage. And this is just a review. I know this is kind of a busy slide, but just to give you the sense of what are the different cancers associated with BRCA1 and 2 mutations, what are the risks, and how does that compare to the risk in the general population. So what you can see here is that for breast cancer, there is an elevated risk between 46 and 87% for BRCA1, 38 to 84% for BRCA2. So very high risk for breast cancer. compared to the general population. And once a woman has had breast cancer, the risk of a second primary breast cancer is pretty significant within 10 years, and this impacts sometimes the decisions that women make about treatment. Risk of ovary cancer is greater with BRCA1 than BRCA2, but both significantly higher than the general population. Again, the idea that men can get breast cancer and prostate cancer, particularly with BRCA2 mutations, is now quite well documented. And a risk for pancreatic cancer, certainly greater with BRCA2 than BRCA1, but higher than the population. There's been some data about melanoma and BRCA2 being elevated, but it hasn't been well documented in the literature. And so what does one do if they have a BRCA mutation? Well, there are sort of three different categories of options. One includes increased surveillance, which for women who are BRCA carriers, we recommend twice yearly clinical breast exams, annual mammograms, and annual screening breast MRI. And the MRI screening begins at age 25. The other option is to do something called chemoprevention, which is taking a medicine that may be preventative for developing cancer. And then the third option, which is the most dramatic, is doing preventative surgeries, either of the breasts or the ovaries or both. And so in terms of thinking about surveillance, the reason for adding MRI screening is because it is incredibly sensitive for picking up cancers. And for young women who are at risk and have dense breast tissue, MRI screening has really been a very valuable tool. And what this table shows is three different studies comparing clinical breast exam with ultrasound, with mammogram, and MRI. And what you can see here is that the MRI is picking up the majority of cancers that are being missed by mammogram, ultrasound, and clinical exam. So really important to add that screening, and that mammogram is probably not sensitive enough for these high-risk women. And then for chemoprevention, there are a couple of agents called hormone blockers. One is called tamoxifen, and one is called a group of drugs called aromatase inhibitors. And these have both been used to treat breast cancer, but have also been used in the setting as a preventative measure. And women who take these drugs for 5 years may decrease their risk of developing breast cancer by as much as 50%. But they are not benign drugs, and it is important to understand the risks and benefits before considering taking one of these drugs. And there are some new trials now looking at a drug called denosumab, which is a bone builder. And people are looking at this in clinical trials as potentially something that may be an agent to take that may decrease risk. And then in terms of prophylactic mastectomies, this is a very big decision for women to consider, but it is something that women who find out they have upwards of an 85% risk of breast cancer will consider. And I think the reason that people are considering this surgery is looking at the risk reduction that you get. And these are 4 different studies, some in BRCA carriers, some in people who have strong family histories, but just showing that having a bilateral mastectomy can reduce your risk between 90 and 100%. So that's a pretty significant risk reducing measure, but it is a personal decision, and people, we encourage them to get lots of counseling, make sure they meet with appropriate providers and really understand what they're getting into. So in terms of the ovaries, so here is an interesting concept, is that if you actually take your ovaries out, particularly before you've gone through menopause, you actually can reduce breast cancer risk. So again, ovarian cancer is part of the BRCA spectrum, so you decrease your ovary risk, but you get this added benefit of reducing breast cancer risk. And that may be greater for people who have BRCA2 mutations and BRCA1 mutations. And the reason for that is that many women with BRCA1 mutations have triple negative breast cancer. So that estrogen, progesterone, and HER2 negative might not get as much benefit from taking away that estrogen. But this is an important concept in thinking about risk reduction. In terms of thinking about ovarian cancer screening and prevention, There are screening tools for ovarian cancer, but they really have been fraught with limitations. The CA-125 blood test and transvaginal ultrasound have not been associated with finding cancers at lower stages or improving survival. And so screening is not really a strong indication for somebody who has a BRCA mutation. Chemoprevention, birth control pills or oral contraceptives have been shown to reduce the risk of ovarian cancer in women in the general population, as well as women who have BRCA mutations. And that risk can be as much as a 50 to 60% risk reduction with 3 to 5 years of continuous use. There is some data to suggest there may be a slight increased risk of breast cancer when birth control pills are taken for a long period of time or they're started at a very young age. So we're always trying to balance these risks and benefits. We get a lot of questions about, using IUDs or Depo-Provera, and there really are no good studies at this point about the effects of those and whether there's any related risks or protections. Again, denosumab, which is being used to look as a bone builder drug, which is being looked at as a risk reduction measure for breast, but also for ovarian cancer. And then the best way to not develop ovarian cancer is to have your ovaries and fallopian tubes removed surgically. And this is a 90% risk reduction. There is a small risk of developing something called primary peritoneal carcinomatosis after the surgery, but it is a great risk reducing measure. However, when it's done before menopause, there can be negative health consequences. So again, this is not something that we take lightly with patients and want to make sure that they meet with the appropriate people and get good counseling about the risks and benefits and make sure they're making the right choice for their situation. The current recommendations for this surgery for BRCA1 is between 35 and 40, and for BRCA2 between 40 and 45. So young ages, and it does mean early menopause, and so those are concerns. So just a couple of added points. There has been a lot of questions about should you have a total hysterectomy, and taking the uterus is not indicated. So that makes the surgery less complicated. It is okay to take hormone replacement if you haven't had a history of breast cancer. And it is important to look for or to monitor for bone density and cardiac risk, because we are doing this premenopausally, and taking away that estrogen can have implications in these areas. So it's important for doctors to be following that. And so there's a newer procedure called a salpingectomy, which is just taking the fallopian tubes and not the ovaries. And in the general population, this is being done fairly routinely when somebody is having any type of gynecologic surgery. And what they're showing is that there may be a greater than 50% reduction in ovarian cancer risk by taking out the tubes. And what we've learned in the BRCA population is that many of the ovarian cancers do start in the fallopian tube and either travel to the ovary or to the peritoneal cavity. So by taking out the tubes, there is this thought that we may reduce ovarian cancer risk. And the benefit would be that you don't have early menopause and the consequences that go along with that. So there are a lot of studies and trials around the country right now looking at salpingectomy and BRCA carriers. So hopefully we'll have some data about this in the near future. The downside of this procedure is that we don't understand if it impacts the ovarian function. So you take out the tubes, do the ovaries continue to function normally? It does require additional surgery down the road to remove the ovaries once you've hit menopause. And you don't get that risk reduction in breast cancer risk. But this is an option, particularly for young women who are not wanting to go into menopause. And then I'd like to talk a little bit about treatment options. So with the advances in our understanding about BRCA mutations and what BRCA mutations do, which is repair double-stranded DNA breaks. And what PARP inhibitors do is target the deficiency in this DNA repair problem. And so this is what we term as a targeted therapy. So we're treating the cancer cells that have this genetic problem rather than taking a drug that affects all the cells of the body. And so there tend to be less side effects. And this is really an exciting area in the BRCA world. And the schematic here is just showing you that, if you have a BRCA deficient cell, that has tried to take an alternative route by using PARP enzyme to continue getting the cell to grow, and then you add a PARP inhibitor, then you cause the cell to die. And PARP inhibitors are now being used in BRCA carriers regardless of the cancer type. So there are now FDA approvals for breast cancer, ovarian cancer, pancreatic cancer, and prostate cancer that are due to BRCA mutations. So this is really an exciting area. The FDA has actually just approved a first-line therapy with a PARP inhibitor in ovarian cancer. So rather than waiting till somebody has metastasized and sort of, it doesn't have other options and then adding the PARP inhibitor, it's moving earlier and earlier in the treatment regimen. And so I've focused on BRCA mutations, and what I'd like to show here is that these other genes, trying to find my cursor here, BRCA1 and 2 are the primary genes associated with hereditary breast and ovarian cancer, but what this schematic is a pathway in our bodies that is involved in DNA repair, and that there are many other genes that are involved in this process, and researchers have been able to find mutations in many of these other genes that are also associated with breast and ovarian cancer. So this has been incredibly important in identifying families that didn't have BRCA mutations in the past, but do have mutations in these other genes, and can be really helpful in identifying risk and screening and prevention. And so if you've had BRCA testing in the past and no mutation was identified, and you have a personal and family history, it is important to think about coming back to see somebody in genetics and maybe think about doing what we call a multi-gene panel. And these are a number of studies that have shown that women who were BRCA negative with either breast or ovarian cancer or meeting certain criteria, and the percentage of cases that had a mutation in a non-BRCA gene. And upwards of 6.1% in this study. So it's not insignificant. And again, we're seeing a lot of people coming back to our clinic who were BRCA negative in the past and doing these newer technologies. And this is just an overview of what the risks for some of these genes, again, showing that BRCA1 and 2 carry the greatest risks, with genes like PALB2, ATM, and CHEK2 being more moderate in risk, but still above the general population and still important to know about. And the same with ovary cancer, BRCA1 and 2 being the big players, but again, genes like RAD51D, BRIP1, and RAD51C, and the Lynch syndrome genes all being important genes to think about. And so with that, I'm going to transition to talk a little bit about endometrial and colon cancer, which are other cancers that can impact women. And endometrial cancer, about 5 to 10% of women with endometrial cancer have an inherited susceptibility. And then the majority of these are due to something called Lynch syndrome, which I'm going to go into some detail. And what's important to know is that if you are diagnosed with endometrial cancer at UVM Medical Center, your tumor tissue will be analyzed or screened to determine whether there's a higher chance of Lynch syndrome. So this is what we call universal screening that was started in about 2018. And we look for the absence or presence of proteins that are made by these 4 genes. And so if you have absence of expression of any of the proteins of these genes, then you may be a candidate for doing more testing to determine if you have Lynch syndrome. And for colon cancer, about 10% of colon cancers are due to inherited mutations, and the bulk of hereditary colon cancer is due to Lynch syndrome. And again, all colon cancers at UVM Medical Center are tested for this at the time of diagnosis. And actually, this is done on biopsy material. So if you have a colonoscopy and you have a polyp removed that has cancer, that polyp will be tested for Lynch syndrome. There are some other rare syndromes associated with hereditary colon cancer that usually involve polyp formation. You can get polyps with Lynch syndrome, but you tend to get fewer than what you might get with some of these other rare syndromes. So if you're somebody who has lots of polyps on your colonoscopies, then it might be worth considering genetic testing for one of these polyp syndromes. So my focus in terms of colon cancer will be on Lynch syndrome or colon and endometrial cancer. And it's about 2 to 3% of all colon cancers and about 2 to 3% of all endometrial or uterine cancers are due to Lynch syndrome. So not an insignificant syndrome in the population to be looking for. And most data about Lynch syndrome was first acquired because of the increased risk for colon cancer. And this is colon cancer in younger people, so the average age of diagnosis being in the 40s. The right side of the colon, which is the ascending part of the colon, is where the cancers tend to predominate, but it can be anywhere. And then what's been learned over the years is that the endometrium or the uterus, the ovary, the stomach, the urinary system, the small bowel, bile ducts, the skin, and the breast is a little controversial, but that if you have Lynch syndrome, you may be at risk for a number of different cancers, not just colon cancer. So the screening and preventative part of this is really important. And I know this is a really busy small slide to read, but this is just giving you a sense of the different cancers that have been seen in Lynch syndrome, what their risks are, and what the screening and prevention strategies are. And so we talk about doing colonoscopies starting at a young age on a frequent basis. Aspirin has been now recommended and has been shown to reduce the incidence of cancers in Lynch syndrome. And then for endometrial and ovarian cancer, we don't have good screening tools. So some women are candidates for thinking about preventative hysterectomies. And then again, some of the other cancers, we have not a lot of great data about screening, but we do work with individuals based on the gene that's in their family and their family history to come up with a good plan. And so like breast cancer, you know, most is due to BRCA 1 and 2, but we've learned there's a number of other genes that can be related. The same information applies to colon cancer. So this was a study that was done out of Dana-Farber where they looked at over 1,000 people with colon cancer, and they tested them for 25 different genes that are associated with cancer risk. And what they found was that 10% of those people had a mutation in a gene that's associated with increased risk. And only 1/3 of them had a mutation in one of the genes associated with Lynch syndrome, and 2/3 had mutations in non-Lynch syndrome genes, some of which aren't even associated with colon cancer risk. So this was really an eye-opening study confirming that, you know, 10% of colon cancer is hereditary, but, you know, a smaller portion is Lynch and all these other genes that could change screening and prevention in families. And this is, you know, for people under the age of 50, particularly important. This was a study that looked at individuals under 50 and found that 16% had a mutation in a cancer susceptibility gene, with half being Lynch syndrome, but the other half having mutations in a variety of other genes that could have implications for screening and prevention. So this is all pretty new information in the last couple of years, and, you know, we really are approaching genetic testing in a very different way because of these studies. And again, thinking about the benefits and risks of this kind of technology, you know, doing something like a multi-gene panel allows us to identify the source of cancer in the family and help families understand their risk and understand appropriate screening and prevention. You know, it's really economical in terms of time and cost, because the cost for testing one gene versus, you know, 80 genes in today's world is the same price. And some of the companies that we work with, if insurance doesn't cover or your deductible is high, there's a self-pay price of $250 for genetic testing. So really the landscape has changed, and results are often back in 2 to 3 weeks, so pretty quick turnaround times. And I think, you know, one of the challenges is when we find a result that's really inconsistent with the history, but would change our screening, you know, while that's helpful, I think sometimes psychologically that can be kind of disruptive to families, and we just have to help them work through that. I think the biggest risk of this technology, or the downside, is that when we start searching lots of genes, we may find variants that we don't understand, what are called variants of uncertain significance. And if you've gone through genetic counseling, you know that we spend a lot of time on this because we really want people to understand that this is not a black and white technology. We may find something important, we may find nothing, but we may find something that at this point in time we are not 100% sure about. And those can be challenging results to deal with. I'm just going to talk a little bit about some of the processes involved in genetic testing, and I think this is an important concept. You know, a lot of people come to us as an unaffected individual who is interested in understanding their risk for developing cancer. But when we think about genetic testing, we really want to test somebody in the family who's had cancer, who has the disease that we're looking for. And the reason is that, again, these are what are called autosomal dominant conditions. So if we test dad who has breast cancer and he has a BRCA mutation, it's a 50-50 chance that he's going to pass that genetic marker or variant to his daughter. So if we test his daughter first and she's negative, we don't really know what that means without having tested dad. And so in terms of the recommendations for screening and prevention are going to be very different if it's a negative result and we don't know that there's a mutation in the family versus if it's a negative in the context of knowing that there's a mutation in the family. So this isn't always ideal, and we obviously do offer testing to unaffected individuals because we can't always find that person in the family who is the best person to test. But this is just an important concept in terms of interpretation. And so just to go through, when we do genetic testing, the results that are termed pathogenic or likely pathogenic are the ones that are associated with an increased cancer risk. There's a negative result, which is inconclusive. Basically, what I just described is we find or we don't find a mutation in an individual, and we don't know whether that means that perhaps the technology just missed a mutation in a gene that was tested for, or maybe there's a different gene that hasn't been discovered or wasn't on the panel that was tested, or perhaps this is a family that has no hereditary predisposition. And we base our risks for that person on their family history. So the genetic testing doesn't really help us in this scenario. We also get the negative conclusive results where there is a pathogenic or likely pathogenic in the mutation in the family, but the person we're testing doesn't have it. And so if it's one of the what we call high penetrant genes like BRCA or Lynch, then that person typically has average risk. Where it gets a little complicated is for some of these more moderate risk genes. If you test negative, then we don't really know all the other factors that are involved in that gene expressing itself in the sense of cancer. And so does that person still have some of those modifying risk factors and might still be at some risk? And again, these get to be complicated conversations, but and then our least favorite result is the variant of uncertain significance, where there's something identified in the sequence of a gene, but it's unclear whether that sequence change has any relevance to cancer or not. Most of these do get reclassified over time as being benign, but at the moment in time that we find it, we just don't know. And so we go back to the family history to make our recommendations. And I just want to touch upon this issue of cascade testing. Because the genes that we're talking about are what we call dominant. So if a parent has a variant in one of these genes, there's a 50-50 chance of this being passed on to the children, 50-50 chance that siblings could carry that variant, and parents, so first degree relatives. And the importance of getting this information out so that those relatives can take advantage of the screening and prevention strategies and hopefully not develop a cancer or find it really early when the outcomes are very, very good. So this is a really important concept, and we really spend a lot of time with families in helping them figure out strategies to reach out to their families. And I'm just going to touch upon this quickly. I know we're getting close on time. So going back to, so what we've been talking about are mutations in the germline, things that are in every cell of the body and have that heritable component. Going back to the idea that all cancers are genetic and that there are genetic mutations in the tumor that may or may not be in the germline, this has been a really important area in oncology, where we're sequencing or looking at the genetic profile of tumors to see if there are mutations that might be candidates for targeted therapies. So the idea that rather than treating the type of cancer you have, we're treating the genetic mutation that is in the cancer. And so we're moving away from treating everybody with breast cancer the same or everybody with colon cancer, and we're looking at the genetic profile and saying, gosh, we're actually going to treat this person more like somebody with melanoma because they have mutations that are targeted towards those drugs versus the ones that we would typically use for breast cancer. But this is a common practice now, is for oncologists to send tumors for this sequencing of the tumor to look for targeted therapies. But I just want to point out, and this is something that I think sometimes gets lost in the discussion, is that if you're sequencing your cancer and you're really looking for therapies, If you have a germline inherited mutation, that is going to show up in your tumor. And sometimes that information doesn't always get relayed back. So it's really important to know that when you're having this kind of testing done, there is the potential to find something that could have relevance for the larger family. And I just bring that up as something that I think, again, the focus of the testing is to look for therapies, but sometimes there is this additional information that's important to know about. And that is all I have to say for today. I just want to put up the people that I work with in the Familial Cancer Program. Dr. Marie Wood is the director of this program, and Mark Greenblatt is another oncologist who has a specialty in gastrointestinal cancers. There are 3 certified genetic counselors that work in this program, and we have a terrific scheduler. And I have also included our website for the Familial Cancer Program. And then also, if you're somebody who is looking for a genetic counselor maybe in another part of the country, I've just put up here the website for the National Society of Genetic Counselors, and they have a great Find a Counselor link that will help you find cancer genetics programs around the country, if that's something that's of interest. And now if we have time, I can take some questions.